Thank you for joining us today. I am Lee Yates, co-facilitator of the TBC at UBC Network and clinical associate professor in UBC's midwifery program in the Department of Family Practice within the Faculty of Medicine. I co-facilitate the TBC at UBC Network with Christy Newton, associate professor and associate head education and engagement, also in the Department of Family Practice within the UBC Faculty of Medicine. Christy is with us today, but apologizes for not being able to interact as she's in transit through an airport this afternoon. Before we begin, I would like to acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people, and the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I would also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that all of you are joining us today from many places. And I acknowledge the traditional owners and caretakers of these lands. I'm joining from the traditional and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples from my small condo right now in East Vancouver. You are welcome to share the lands from which you are attending in the chat if you wish. Now I'll hand over to Ben Fair, Assistant Director, Health Systems at UBC Health, to talk more about the TBC at UBC Network.
Thank you, Lee, and hello, everyone. Thanks for joining us. The TBC at UBC Network is supported by UBC Health, which works under the Office of the Vice President Health to help address complex challenges affecting the health and well-being of individuals, communities, and societies. UBC Health facilitates collaborations across disciplines, faculties, external partners, and communities to improve the ways we train people, develop knowledge, and shape policy, to ultimately address inequities and improve the systems that foster and support health. The TBC at UBC Network convenes health professionals and leaders, community members, academics, and policymakers to bring forward questions and ideas that are important for team-based care in BC. The network supports and complements province-wide efforts to enhance team-based care in BC by focusing on education, research, evaluation, and knowledge translation, and by enabling participants to learn from each other and connect their efforts. Each network event applies a different lens to the themes of research, pedagogy, and innovation. Back to you, Lee.
Thanks, Ben. I think before we start and share more about today's session, we'd like to start with a poll and just to ask which perspective you bring to the conversation today, to get a sense of who's in the room with us. Looks like we have a lot of clinicians in the room with us today. Fantastic. About 50%, 55, 56%, almost getting closer to 60 of the folks in the room are clinicians today. We have some health administrators and faculty and staff. And a couple of students with us as well. Thank you for joining us. So let's talk about today's session. Today's session will focus on how counseling and the mental health professions can play a role in team-based primary care to help respond to patients' behavioral and mental health needs. Mental health concerns have escalated in recent years and added to pressure to meet community health needs in BC. Family doctors have increasingly had to respond as mental health care providers. And so today we're asking, how can counseling professions, so psychologists, counselors, social workers, and other care providers, play a role in team-based primary care to help respond to patients' behavioral and mental health needs sustainably? We're asking what developments are happening in BC in this field right now. And with these questions in mind, I'd like to begin today's session with our panelists giving brief presentations that reflect the TBC at UBC themes of practice innovation, education, and research. Briefly, our panelists are Erika Penner, and Erika is the Director of Advocacy at the BC Psychological Association and Psychology Lead at Vancouver Coastal Health. Zach Finley is Practice Lead, Clinical Counselling at Vancouver Coastal Health. Bridget Beachy is Director of Behavioural Health at Community Health of Central Washington. David Bauman is Behavioural Health Education Director at Community Health of Central Washington. And Simon Elterman is a registered psychologist with Elterman Psychology. Following the presentations, there will be time for dialogue, both in smaller group breakout rooms, and we'll come back together as a larger group. But we'll share more about that after we hear from our speakers. Simon, I think I'll hand over to you for the first presentation. Welcome, thank you.
Thank you for that introduction, and I appreciate everyone being here. Again, my name is Dr. Simon Elterman. I'm a psychologist in BC, and I've been working in primary care for several years. I'm also the chair of the Advocacy Committee, so I work alongside Dr. Penner a lot. And today I'm going to talk about a couple of different things. I'm going to define why we need mental and behavioral health in primary care and what that would actually look like, and just giving a few studies of how it actually helps and benefits people. So I will get started. So I'm going to cover three broad topics in 10 minutes. One is, why do we want to be in primary care? Why is that important? What could it look like, and how is it different than your traditional mental health practice? And does it work? And I'm going to highlight 3 different countries or regions that are doing it really well and some of their data. So first of all, why primary care? Why do we care? Here are some numbers from Canada. 90% of all deaths in Canada are from non-communicable diseases. So things like hypertension, diabetes, cardiovascular disease. 44% of adults in Canada over 20 years old have one of the top most common chronic illnesses. So those would be things within that non-communicable disease. So this is something that has a huge impact, and it affects a ton of people. Also, this costs the government money, right? $68 billion annually for healthcare expenditures due to these non-communicable diseases. And what we know about these non-communicable diseases is that there's a large component of them that are related to things like lifestyle behavior change. So things like smoking, diet, sleep, and exercise, substance use, all those kind of things. And finally, part within that lifestyle behavior change and all that stuff is mental health. So 20% of Canadians per year experience some sort of mental health issue, and that goes up to 50% if you look at across the lifespan. So 1 in 2 people in Canada are going to experience some sort of mental health issue in their life. So what does this have to do with primary care? Well, primary care is the entrance for people. 70% of people with mental health issues don't seek help. But in that same time period where they're not seeking help, they're going to see their general practitioner, they're going to see their family physician, right? So this is where we can get people, right? So we talk about, where do we set up places to catch people who aren't getting help? The place to go is where they're going, which is primary care. So let's say they do go to primary care and they see their family physician. 70% of family physicians say that they have a difficult time getting resources for their patients. And right now in BC, primary care physicians don't have a ton of resources, right? So to be able to have someone in the primary care network to help these people is huge. So I just want to highlight one other thing, right? Which is suicide, which is something that we talk about a lot, right? In North America, right? Within the year that someone will complete suicide, 77% of people will have seen their primary care physician within the year, 45% will have seen them within the month, 20% will have seen them within the week, and if people are hospitalized, 9 people will complete suicide the day that they're discharged or within 24 hours. So primary care is where people are going, right? And working on the downtown east side in Vancouver, this is also where people who have things like substance use issues are going, right? So this is where people are going. So what could someone like a counselor or behavioral health, we call them behavioral health consultants, right? Because we're really consultants for the physicians. So what might this look like? So this is my wordiest slide, I promise. So I've taken some information. We have the primary care behavioral health model. There's a ton of great definitions. And then also Dr. Lutz, who's going to be joining me in our breakout room, also put forward another few things. But what I like to say to people is think about your general practitioner. The oxymoron is you need a ton of specialized training to be a generalist, right? So you see everyone at every age for any problem. It's ongoing care, right? So it's not like traditional mental health where you go in for your depression, the person helps you, and then you're discharged. You would never go to your family physician, get help, and then you're discharged from the practice. You come back for whatever issues you need. So a behavioral health consultant in primary care is there for ongoing care, right? And the way that it's also specifically, there's training, and doctors Beachy and Bauman are going to talk about this, is you see people briefly, 15 to 30-minute visits, and every couple of weeks, and typically 1 to 6 visits, right? So you have a caseload that is 2 to 4 times greater than your typical mental health practitioner out in the community, right? And this model isn't meant to replace that, but it's meant to be a supplement somewhere, or someone who can be in primary care. Again, if a behavioral health clinician or BHC is in primary care, they're going to be in the same EMR, right? The electronic medical records. So the notes that I write, the physician sees, and the physician writes their note, and I take a look, and we're all part of the same team. We're all under the same umbrella of informed consent. And so part of all of this is that people have access to high quality care. They don't have to wait weeks or months to get a referral. And most people don't actually follow up on the referral anyways. So you can have something called a warm handoff, right? Which is where the physician sees the need for a BHC to come in, and they bring you into the room. And the warm handoff is like, hey, I'm going to hand this person off to you. I'm going to go into the next room, right? And so not only is that great for the patients, but behind the scenes, we're able to consult and help with these kind of cases where someone comes into primary care. So psychologists, BHCs, counselors, anyone who's trained in this model, they're experts in lifestyle behavior management, chronic disease management, and we're functionally driven. So that means we look for not just symptom relief, but actually making people's lives better. So that was my wordiest slide. So I just wanted to show what a day in the life might look like. How does this look on the ground practically? So this is a template slide. So all days that I'm in clinic, I have spots for scheduled patients and spots for warm handoffs. And again, warm handoff is where someone brings me into the room and I meet the patient. I do a quick 15-minute visit where they get some sort of assessment and treatment. And then sometimes people get what they need out of one visit, other people come back for follow-up. So, and scrubbing, by the way, is at the beginning of the day, I look who's coming into clinic that day and seeing if I can maybe go in and help out the physician, and I talk to them before the day starts to say, hey, I see, John Doe is coming in. Looks like they might need my help. If you're running a little late, I can go in before you. Otherwise, I've blocked off that time for me to come and see them. So this is just an example. Again, this is a lot cleaner than how it actually looks. Usually it's a lot messier, but DMII is type 2 diabetes, MDD is depression. So someone might come in with 2 issues, right? So what we're trained to do is be experts at complexity. So you can have people with diabetes and depression. You can have people with chronic pain, BPI, bipolar 1, and sleep issues. These are very common. Medication adherence, cardiovascular disease, CVD, GAD, generalized anxiety disorder, PTSD, post-traumatic stress disorder, OUD, opioid use disorder, and pain. These are all just kind of typical things that I might see throughout the day. And you have to be able to kind of be flexible and see all of these people. And you can see everyone's at a different age and different, gender presentation. So that's what it might look like. This is kind of non-traditional things I just wanted to highlight. So things like giving an educational presentation to certain providers, right? So often I would give presentations on how to do a suicide assessment, a risk assessment, right? To all the providers, so everyone knows and everyone's on the same page. Do a visit with a GP. So there might be a visit where I'm there with the physician and all 3 of us are in the room with the patient and we're all making a plan together. Sometimes I might get called in someone who has needle phobia, they're having a panic attack. Again, suicide risk assessment. Physicians, they're there to help the patient, but these risk assessments take time. And if they could hand it off to an expert, that saves them a ton of time. It saves the healthcare system money. Medical decision-making, case consultation. So these are all kind of things that we can do in primary care that could help the patient, that help the physician, both in terms of resources and time. And I'm sure there's going to be tons of questions about that. So does it work? Short answer is yes. We have a ton of from different countries that it improves patient outcomes, it reduces care provider burnout, it improves patient experience in the healthcare system, and it helps reduce costs to the system in all different areas. So I just wanted to highlight 3 different countries where this has worked really, really well. So one is Canada. So we think, oh, this is new, this is cutting edge for BC. This has actually been done, right? There's a 3-year pilot project with a couple of psychologists where they saw on average 3 sessions, so between 1 and 6 sessions of a psychologist in primary care, patients had significant reductions in anxiety, depression, suicidality, and significant increases in kind of life functioning, well-being, quality of life. And after a few years, the funding was cut. But when people talk about, would this work in BC? It's already worked in BC. Next is New Zealand. So New Zealand, the reason that we like to bring it up is New Zealand has the same population and healthcare expenditures as British Columbia. So if they're doing something and it's working really well, chances are that there is some crossover that can happen. So there is some data I can share with people, but basically in terms of access, what has been found from preliminary research is that the Indigenous Maori and Pacific Islander population has increased equity and access to healthcare as compared to before we had, they call them HIPs, so health improvement practitioners in New Zealand. And then the final thing I want to highlight, and I know I'm a little over time, is in the UK, they have the increased access to psychological therapies, and they have a bunch of open data. And I just want to read the data from one part of it, which is, so outcome measures from these 2, Cambridgeshire and Peterborough, found that urgent care visits fell by 61%, hospital inpatient admission fell by 75%, GP appointments for diabetes, cardiovascular disease, and respiratory disease fell by 73%, and that these findings were demonstrated across a bunch of different regions. And this has been replicated in the US and in other countries. So this is just some examples of how it's worked in BC and in other countries. So I hope I've explained why we're doing it, what it is, and how it's been working. And here are some references for today. And here's me looking happy, and here's my email address if anyone wants to reach me. Thank you.
Thanks, Simon. That was a great quick and dirty summary of the BHC model. My name's Erika. I'm a registered psychologist and the director of advocacy for the BC Psychological Association, and I'm joined by Zach Finley, who's the lead clinical counselor for Vancouver Coastal Health. And what we're here to talk about is really how that primary care behavioral health model fits here in BC and where we're at as a province. So when we think about this model that Simon has described, and when we look at how it compares to the primary care network visions and goals, they're actually quite similar. So when the NDP government proposed the primary care networks, they described it as, moving BC towards integrated team-based care, that we would have streamlined referrals, greater support for our overburdened family doctors, and overall improved access to care for patients by giving them greater support from a multidisciplinary team. So this was supposed to be really quality-based, transformative, integrated, collaborative care that was easy to understand for those using it as well as for those who work in it. And really, we see that vision for the PCNs from the NDP really was held onto and carried forward by our primary care networks. This is just one example from the Vancouver PCN Service Plan Phase 2. They said the goals for their PCN was to provide the right care in the right place at the right time. And again, you can see how that's really, really consistent with a behavioral health model, where we have people right in clinic working side by side with family doctors, able to provide care for whatever the patient needs, whether it's, pain management, difficulties with overweight, trauma, PTSD, substance use, whatever it is. So the vision, I think, is quite consistent. And, I would say overall in BC, there have been some obstacles to really having this vision become a reality. So that's what Zach and I will focus on today, some of the obstacles that we've encountered, which is normal, and how we can move forward.
Thanks, Erika. Yeah, and I want to acknowledge just, so one other piece about my role. So I'm the practice lead for clinical counseling for Vancouver community. So that means I support about 125 clinical counselors in Vancouver who work for Vancouver Coastal Health across a range of teams, and one of those teams is about a 22-person clinical counseling team in the Vancouver Primary Care Network. So that's some of the experience I'm drawing on when I'm speaking with all of you today. So I want to acknowledge that's kind of more specific experience, and I think what we really want to look at is broader. It's really how do we do this all across the province, but I'm hoping that the experience that I can share with regard to Vancouver and the Vancouver Coastal Health region more broadly is relevant to other places in the province as well. I think in many respects it is. So yeah, this is the lay of the land here. We have 59 PCNs right now across 24 municipalities. There are collaborative service committees, 24 collaborative service committees that support this work, and they are implementing diverse service plans across the province. Those committees, as many people on this call I'm sure know, are made up of folks from divisions of family practice, folks from health authorities, and community members and partners, including in some places First Nations partners as well. But really working across those different systems is, I think, one of the challenges that we're up against. And I'll say a little bit more about that. Next slide, please. So the challenges. The first thing I want to say regarding challenges more specifically is we have a lot of very skilled mental health and behavioral health professionals who are working in primary care throughout this province as part of PCN initiatives in a wide variety of settings. I know the team that I primarily support here in Vancouver are just really doing a bang-up job. And the model that they really are embedded in is presenting some significant, I think, challenges, especially if we look at sort of what the best practices are that Simon just kind of laid out for us. So more specifically, some of those challenges are each PCN has really undertaken the implementation of behavioral health and mental health services in team-based primary care environment independently. Again, so it's looking really different in different places. There's no overarching kind of model or support like the behavioral health consultation model that we're talking about today. There's an assumption of expertise in specific training. So there's this idea, well, you know, these mental health professionals have all these transferable skills. Let's just put them in a primary care setting and, you know, support all these patients that didn't have access to services previously. I think probably Doctors Bowman and Beachy are going to talk a little bit more about why that might not be the best way to approach the behavioral health care in a team-based primary care setting. Services aren't co-located, so that's a key part of the model that Dr. Elterman was describing. There's really, co-location is one of the things that really facilitates that integrated and collaborative service, and that just has been a huge challenge, I think, here in BC. There's a lot of remote service happening because a lot of the service was set up during the pandemic. It's one thing to set that up, to have remote services when things might sort of be initiated in a co-located fashion, and then some hybrid work happens as part of that. But sort of starting out virtual has been really hard, I think. What else to say about that? Well, I guess just to acknowledge, I think one of the barriers around co-location is just the costs involved for our GPs too, that there's overhead there, and that's a significant barrier as well.
Thanks, Zach.
Erika.
Yeah. So I think there are these foundational challenges in terms of how the primary care networks were initially rolled out that we've seen. But there is also a cultural shift, I think, that we need to undertake in BC that's really not specific to the primary care networks or kind of the the messaging around them. And that's a real shift in terms of how we think about psychology and counseling services. So, when we think about mental health treatment, we think about, 50-minute, 1-hour appointments, weekly, perhaps. A lot of the research that is done or has traditionally been done in mental health is, on 12-session treatments for anxiety or depression. So I think when people think about what a psychologist or a counselor does, they imagine that, I go in weekly for an hour and we deal with this one problem. And really, that's not at all what the behavioral health model looks like in terms of how we use the skills of counselors and psychologists. And I think also part of what's been a challenge is that we often think about mental health treatment as being specialty care. So it's hard. I think it's been hard for us to adjust ourselves to think that actually this is really foundational primary care. And I think what's happened in a lot of the PCNs that we've worked with, which are, by no means all of the PCNs in the province, is that although it's meant as primary care, our mental health treatment services have ended up becoming specialty care. There's ended up being a referral process, a form sent, and someone goes somewhere else at a later date. And so even though it's meant to be primary, actually that looks a lot like secondary or specialist care. I think another barrier in terms of our understanding is just that I think we think about psychologists and counselors as being mental health specialists, and that's correct. But this notion that psychologists and counselors are actually experts in behavioral health treatment, or some have the skills, or we can train them to have skills in the treatment of chronic physical health conditions. That's a new idea, I think, for a lot of folks in BC, maybe not people on this call. But I think, when we look at the literature, we know that behavioral health services are absolutely critical to reduce the morbidity and mortality related to chronic physical health diseases. And yet when we hear, often when people talk to us, they obviously often assume you're for mental health treatment and miss that actually, in many ways, chronic physical health diseases are what cost us more in terms of funding, but also in terms of, the impact on people's quality of life. I think another challenge is just thinking about psychologists and counselors as part of a team. I think, and I take that on as a psychologist. I think we often are protective and feel that confidentiality rests with us, that we protect our clients' information. And while that's true, and often, in other settings, especially specialist settings, in team-based care, that doesn't work. We have to share information. We have to work as part of a team. And the other big shift we need to make here in BC is thinking about mental and behavioral health treatment as being longitudinal. We really do think of it the way that Simon described as, we go in for treatment, and then when our treatment is done, we leave again. Whereas in fact, that's not at all the model. And we know that what really works is when we see our behavioral health consultant, whether it's psychologist, counselor, or someone else, on a regular basis when something comes up, and we don't need to fix everything in 1 or 2 appointments, but that they're creating a relationship with us, and we're moving through our lives with them. So when things come up, that they're available, whether I'm hitting this age and I'm gaining weight, or I've developed diabetes, or I had a car accident and now I have PTSD, whatever it is, that they're there with us along the way.
And you build a plane while you're flying the plane. This is a metaphor that we hear a lot in healthcare and healthcare decision making. I think it speaks to the wish to really be nimble and creative under difficult circumstances. And I think all of us who work in healthcare appreciate the importance of that. But I think the metaphor is also potentially instructive insofar as you cannot actually build a plane while you're flying. You need to have a plan first, right? So I think that's part of our wish here, is to kind of articulate a plan and a framework that could effectively be utilized. So
and Zach, can I just add that I think sometimes, like now with the PCNs being rolled out, sometimes as we meet with different groups, we hear that even though there wasn't maybe a really specific model or framework or training at the beginning, that people are feeling like, okay, but we really want to sort of meet the aspirations of behavioral health model or something that looks like that, but they're kind of doing it as the PCNs are already being rolled out. And so I think is that, am I getting that right?
Thank you. Yes, that's exactly that's a significant challenge, I think, that we're facing. So part of the things some of the things that go along with that then are just the really rapid speed of change. So we've had these kind of bulk hires. A lot of people have been hired in very short order. And there's been a focus on outputs like a number of FTEs filled, rather than really looking at the kinds of outcomes that Dr. Elterman was describing. Are we actually improving the health of the population, improving the experience of care for our providers and for staff, reducing per capita costs of care, like these really important outcomes. And we need to have key performance indicators to measure those things, right, as well as just our outputs. I also see a message here from Nikita. Thank you, Nikita. I see that my data was a little bit old regarding how many PCNs we actually have. There are 62 now across British Columbia. Thank you for that.
And Zach, can I just add here that I think there's been a real openness from the PCNs to have outcome measurement, and I think the one we've seen the most often is patient satisfaction with it, which is a really important outcome. But I think overall we want to see a greater level of outcome measurement, and so for folks to know that no matter where they're going, they're getting treatment that works. Is that fair to say?
Absolutely. Yeah, and I think moreover, having ways of measuring outcomes that are kind of standardized. I mean, might be pie in the sky, but ideally across the province, like we want to have a shared understanding of looking at, how we're doing with our outcomes, right? Thank you. So this kind of speaks to some of the cultural push and pull that we have in terms of implementation around behavioral health and mental health services. With primary care in the province as well. Spoke to that kind of difference is in culture and decision-making structures between the divisions of family practice and the health authorities. I don't know who's who in that image. I think it probably depends on the day, depends on who you ask, but there is that challenge just around collaboration across these very different systems, health authorities being in many respects pretty hierarchically organized, complex decision-making bodies in a unionized hiring environment, and then family doctors and NPs coming from a very different sort of framework. So I think that's one of the challenges that we're up against too. The pilot project that Dr. Elterman referred to earlier happened within VCH clinics, so that was something that really I think made it in some ways a bit easier. And one of the things that we're struggling with now is how do we really work across these systems? Not having a shared EMR is an important part of that too, a shared medical record keeping system. So the health authority sort of has one, and then these clinics all have their own as well. So that also really impacts our ability to collaborate effectively. And different things are happening with that across the province, but that's been our experience here in Vancouver.
Thanks, Zach. And just to end off, moving forward, kind of, sometimes folks ask us, well, what can I do? Like, I want to do something. I want to, improve our ability to provide team-based care and primary care, or, adhere to a behavioral health model. And I think in terms of the team-based care, what we really think about is, for people to start talking. This is so important, whether you are a mental health or behavioral health provider, talking to a GP, or even your own colleagues. I think by, thinking of ourselves as part of a team, we start to behave like we're part of a team. The other thing you can do is contact us. I have my email address here. Anyone is free to email me anything they would like, and I'm always happy to chat. And the other thing I want to mention at kind of a macro level is that the BC Psych Association does currently have a primary care psychology proposal in front of the government right now. This looks at implementing psychologists in primary care across BC, but in a centralized model, so that no matter if you're in Burnaby or Powell River or Kamloops, that you would receive the same level and quality of care with measured outcomes, regardless of which location you're in. And that would be a first step. We fully recognize the critical importance of counselors, social workers, and other allied health, but it's the idea is to start somewhere and have a real centralized model of behavioral health care integration to start with. And I'll turn it over to Drs. Bauman and Beachy.
So my name is Dr. Bridget Beachy, and I'm here with Dr. David Bauman, and we are just so incredibly grateful to be here. It kind of feels like a surreal moment. We had got to work with Dr. Elterman when he was going through his internship in the United States, and just we're really glad to be acquainted with him and the rest of the group here. So we're kind of asked to be a part of this call to kind of talk about maybe aspirationally what could happen down the line. As you all had mentioned, there's varying levels of how far advanced integration efforts are. And we all know that anything in healthcare can take a long time. And we also know that, as it was going on in the chat, that oftentimes regulations can make it even more difficult. So it's just the overall context in some cases that make it even more challenging than just the actual nuts and bolts of doing it. So we just wanted to go through a few slides, and we will keep it nice and short, y'all, about that PCBH can work. So PCBH stands for primary care behavioral health, also known as the behavioral health consultation model. It's all from the similar, same perspective. So this is from Dave and I's system. We started working at an organization in the Washington State Community Health Center with high acuity needs and, again, regular primary care services. And they started integrating behavioral health consultants back in 2007. But there was only one for a huge, huge system. And then we were brought on in 2013 and 2014 and really kind of started building the infrastructure. And then in 2016, Dave and I became the directors of the programs. And we went from having about 4 people on our team to, at this current date, we have 18 behavioral health providers working in our system. And these are the total visits rendered each year across the system. And you can see, even in 2020, we were still seeing tons of patients. And once we kind of got back on track with all of COVID, we were able to jump up even more so. And so the demand, as we often say, if you build it, they will come. So as we've built it, the demand for behavioral health services has gone through the roof. And as much as we have multiple BHCs working at all of our locations every single day with really good coverage, it still, quite frankly, isn't enough. And we have just got 3 more requisitions approved in our system. So that's how insatiable the medical system is for behavioral health services, which is exactly what Dr. Penner and Elterman and Zach were saying. So you can't just, like we're saying, take a bunch of very highly skilled folks, but just throw them into the primary care setting and expect for really good things to happen. We have to train and retrain our workforce. If you think about when somebody graduates from medical school, they still need to go through residency. There still needs to be, as Dr. Elterman was saying, the irony that you have to specialize in being a generalist, because there's so much information that you need to gather. Throw in another wrench with regards to working in a completely different setting where most counselors, psychologists, and mental health professionals were not trained to work in medical settings. We weren't trained to work with medical conditions. So that's all upskilling that we have to do. And what we found in our system is that you are paid back in spades by doing a lot of work at the front end. And, a few other, cliches: an ounce of prevention is worth a pound of cure. And we take that absolutely to heart, because when we onboard our BHCs, we have to help them to understand the mission of primary care, which looks different than the mission of specialty care. We need them to understand that primary care is often the first place that people go for services. There's continuity of care, as our other speakers have alluded to. It's comprehensive and whole person care, hopefully, and a high amount of coordination of care happens in primary care. The other thing that we're striving for our BHCs to be is a generalist and be highly accessible, team-based, high productivity, and educator and routine. And so our nice little acronym that we use for that is the GATHER approach. There are 6 different competencies that have been laid out by other researchers. And again, this isn't just something that was that one person made up independently. This is actually the core competencies that was developed by a psychologist who went to New Zealand and set up their entire system, operates from these core competencies. And so when we're in our system, these are the core aspects that we're training our behavioral health consultants on. And Dave, did you want to add just about, I guess, with you creating and being in charge of our education program, how that models, that training process?
Yeah, no, I think it's a really great thing, and I can't echo Bridget enough, just my gratitude of being here and just all what you all have taken on and the comments already. But I think the intentionality that just needs to be shown with this trainees, I think it was Dr. Finley, I think you were saying about how this can sometimes be a difficult thing because, behavioral health providers, we might just assume, oh, we could just put them into any system and they can just do what they've been taught to do. And as Dr. Piener and Dr. Elterman were saying, this is a very different approach and philosophy and undertaking, not only about the longitudinal aspect and providing care episodically, but as Bridget was saying about the vast array of different things that we're focused on. So we've taken that to heart about when we get, this is why we establish a training program, both as an internship and a fellowship for our psychologists and master's folk, is that this is a retraining. And maybe not retraining, might not be the best word, but maybe an amplification of what training people already have to make sure that they're functioning well within this context. It might be a little bit different from the specialty care.
Yeah, and we've just found that when we're taking core behavioral health consultants who are licensed folks that are joining our team, minimum 8-week onboarding, minimum. And that's putting them with this scaffolding and shadowing approach where they're shadowing the different members of the team, not only the BHCs, but they're shadowing PCPs, medical assistants, nurses, reception, as well as shadowing the BHCs and getting more and more independent as we do that scaffolding. And Dr. Bauman is in charge of our pre-doctoral and postdoctoral fellowships. That's essentially the folks that are in their final stages of getting their doctorate to become licensed psychologists. It is a 1 to 2 year situation where we're doing 2 hours of supervision individually every week. There's 4 hours of supervision in the group format. And this isn't to scare everybody and say, oh my gosh, this really overwhelming thing is completely impossible to do. The point is that it can be done. It can be done well, but there has to be that intentionality in that, as you guys were saying, that blueprint and a plan all along the way. I did put in this little slide here.
Bridget, and I just want to, can I pause you real quick? And I know
Yes.
we are conscientious of time. We're going to wrap up here. So the one thing I just want to call attention real quick to the comment that came in from Sarah about the more practices with this model, the more exposure our medical students and residents get to this model of care. And it's something that we have a benefit with. Not only do we have a fellowship and an internship for psychologists, we also are housed within a family medicine residency. It is mind-blowing to see what happens when these trainees start together, go through orientation together, work together, get to learn from one another, and then when they leave to go out to their other practices, that they expect this team-based approach from their inception is kind of imprinted on them. It is a really, really cool moment.
Yeah, absolutely. And we just provided this slide just to kind of juxtapose that specialists and therapists that Dr. Penner talked about so well with the differences seen in the consultation model and in PCBH. And again, that ounce of prevention is worth a pound of cure. We have folks in our system who had never did any training in integrated primary care who are absolutely flourishing in this role just because of how strong that onboarding and structuring is and that intentionality of that philosophical shift. So there are so many resources out there. Collaborative Family Healthcare Association in the United States, although they have an international presence and are attempting to have more of an international presence. There's books, there's articles. These are some of the really main ones. And then Dr. Bauman and I, in our spare time, we upload a bunch of training videos to YouTube. We have like 100 of them or more. We actually have demonstration videos of what a handoff looks like, what the actual clinical visits look like, and that can be found by following that link. So Dr. Penner, I'm happy to stop talking so we can go to the breakout groups.
Thank you, everyone. A generous thank you to our panelists for the presentations. I feel really excited and energized hearing about what you've shared and about what's happening and about what's possible. And with I could hardly keep up with the chat. So with the enthusiasm in the chat as well, it looks like this resonates with others. Keeping an eye on the time, we had planned to move to breakout rooms. But I think knowing that a few people may have to leave just as 1 o'clock approaches for other things, I wonder if we might pivot and just stay within the large group and have a fulsome discussion. I'm seeing some nods from our panelists. Thank you. Have a fulsome discussion within the large group. So just before we do that, we will stay in the conversation in the room until 1:30, and folks are invited to stay with us, recognizing that some people may need to leave as the clock kind of passes, but we'll stay and continue the conversation. Just before we move to the conversation, some of the things that I would have said as we were closing, maybe just before folks that do have to step out go, and so that we don't disrupt the conversation in 10 minutes, I'll deal with some of those things first. So just to mention that the recording of today's presentation will be available on the UBC Health YouTube channel. So you're welcome to share it or go back and watch it later on. Our next TBC at UBC Network event will be on Tuesday, May the 23rd at 12 p.m. And an invitation will be sent by email. Our speakers for that session, in addition to being leaders at UBC Health, bring a wide range of perspectives and backgrounds. Donna Drynan is Associate Head of Fieldwork and Clinical Faculty Affairs in the Department of Occupational Science and Occupational Therapy. Kim McGrail is the Scientific Director of Population Data BC and the SPORE Canadian Data Platform, and a professor in UBC School of Population and Public Health. And Ray Markham is Executive Director of the Rural Coordination Centre of BC and a physician in rural family practice in BC. Why don't we open the floor for conversation?
It looks like there was a question. PCN is not co-located mostly, so we are not in the office with any GP. How could you adapt this, or can you at all to suit more of this model?
In Burnaby, Dr. Leslie Lutz and I developed a behavioral health model that was more focused on chronic physical health diseases, and it launched during COVID. So we actually had to do everything virtually because it was like right at the start of COVID, where we were all terrified even to look at each other. And so I think absolutely it can happen, but it has to be really deliberate. And I think there have to be other efforts to create that sense of team. But certainly, you can do warm handoffs virtually, right? There can be someone on call. There can be, we're all way better at Zoom than we were 2 years ago. So I think I think it really, for me, it has to come from the top of this is the model of team-based care we want to use. This is the training that we're going to provide to your staff, so they all are providing the same type of care, so that the physicians know exactly what to refer for and how to make that referral process basically non-existent. In Burnaby, we tried to forego any kind of form or thing you have to fill out. So it can happen. I just think there has to be a lot of thought and planning put in place. That's just my perspective.
Yeah, and perhaps I can step in, Erika. I'm Dr. Lutz, and one of the advocacy directors for BCPA and a professor here at UBC Okanagan. One of the things that we found was the warm handoff from the provider, or it was a cold handoff, but it became a warm handoff virtually. We completed a study this past year, independent of Burnaby, to see what do people really think about it. And over 500 young adults who did this scenario to see what a virtual warm handoff would look like, not one of the 500 people said they would not engage in mental health services as long as the warm handoff was completed. This is a paper that's currently in press. It should be published this week in the Patient Medical Internet Research. So what I can tell you is that even in our virtual world that we sometimes are limited to, and we have the limits of co-location, let me be clear that these are people that were reporting moderate levels of anxiety and depression, and not one of the 500 said they would not engage the service with the 2-minute virtual handoff from the physician to the client.
Yeah, I think that underscores the absolute importance of the on-demand, that accessible piece, right? In real time, the amount of folks who say, once they stop and think about it, that you get in your own head, oh my gosh, what's this going to look like? And then photos of or images like Dr. Penner had in her PowerPoint pop up. It's what are they going to ask me to do? Whereas when we're able just to get it done, it's oh, well, that wasn't so bad, and that's just part of my regular care. And patients by and large love it.
And Bridge, to carry on that, Dr. Lutz and Dr. Peter, I agree. Like that is just so awesome. And one of our mentors, Kirk Strassel, who's also one of the second authors, or is the second author of Acceptance and Commitment Therapy, and one of the grandfathers of primary care behavioral health, he said something that was really interesting that one time. He said, honesty is like what I think works in PCBH, and there's a lot of things that work in PCBH, but we look at the variance of what allows PCBH and these integrated models can work. Is Dr. Penner, something that was on, I think, your slide, that was like, the care happens right now, in the moment that is being requested. The power of that just is something that just ripples out exponentially within those moments, those interactions. So I don't know, that study, Dr. Luke, that is so cool that you shared that. That gets me hyped.
Hi, I'm Dr. Condello. I'm a pediatrician in Victoria. I appreciate I have two other pediatricians that work with me. I think we have a unique practice. We've recently joined a nurse practitioner group, so we're working collaboratively with them. My question that I would love for us to have further discussions about, and this is a struggles that I've been having 20 years of my career, and certainly in BC, I would say. I've worked in other provinces that things worked way better, but is the challenges with communication. So most children and youth have to go through child-youth mental health. I work super, super close with child-youth mental health. I'm at the eating disorders program as well. I work closely with schools. My partners and I have established school-based programs as well in middle school and elementary schools. The challenge is, again, the segmentation of communication. And, for us to communicate effectively with the counselor, the therapist, and the few psychiatrists that we can maybe get linked with these complex kids is very, very challenging. We work at different facilities. Who pays me when I'm doing these group sessions? I have become creative with regards to my MSP billing. That is legit still, but still I lose a lot of hours not being able to get compensated for that. Wasted time with multiple physician appointments for all these kids and families, like consultations galore, that if the governments just look at streamlining, it would become so more feasible. And we can catch these kids and youth early on in their diagnoses. I full-heartedly believe that, early preventative anticipatory guidance is what is required. It's still not being done. And so, I know it's open-ended, but I just think like great ideas, but, just being able to get everyone under, like my thoughts are, and I think there's many head shakings that are occurring as well, is that, we need to be looking at more facilities where you live in this environment. This is your hub that you go to, and in that hub you see like everyone is there, not just segmentation. So I'll end it at that. I know I've been rambling, but if I can get some feedback from those who have comments, that'd be great.
So perhaps maybe I can speak to that. And Dr. Condello, thank you for everything you're doing for children, right? It's so incredibly important, the work with children early on. One of the things that we're going to be advancing in our proposal, so our original proposal to the Ministry of Health was in November 2021. We're at the request, we're revising the proposal or updating, I should say. It will be going back in on Tuesday. And one of the things that we're going to be incorporating is the launching of a system that, just like we have requisitions for blood work in the province, and any physician and provider can go in and log in and pull that information to make it part of their data-driven decision-making. We're going to be supporting a launching of a system that will speak the same language, so that for assessment and metrics for mental and behavioral health, just as we do with physical blood work, and a way that we can have provision of communication in real time that decreases a ton of the issues that exactly you're talking about. The inefficiencies that our medical providers are having to deal with, and our behavioral health providers, is just astronomical waste of money and time and is actually not benefiting the patient. So that is one of the things that we have really spent several months working on as a system. Again, just like we have a system that you can go into anywhere in the province, right, and access a patient's blood work and have that communication, we're going to be suggesting for evidence-based, right, assessment for both, and again, choosing these which elements or metrics, mental and behavioral health factors, that we want to be collecting and gathering as a part of patient decision-making with the physicians. So I feel your frustration, and we're trying to hopefully establish at least something as a starting place for us to have more of a base system, right? And that can be accessed and communicated in an easy way.
I just wanted to share, some of the problems we've had in Northern Health. I'm from Prince George. There was a previous iteration of what we called IPTs, interprofessional teams associated with primary care homes, that Northern Health, actually, the only time I've been here since 2001, the only time we were like ahead of the game and we started early and we were, early leaders of it. But talking about blueprints for things being developed before the plane takes off, we are now left in a situation where before this system went in, I could discharge a patient from hospital. I'm a psychiatrist, and they would get into the specialist team therapy system within 2 weeks for an inpatient person referred and 6 weeks from the community. Now it's 10 months, and we have 14 of 25, like within specialty teams, we have 25 therapists in this small community of 150,000. And in primary care, they have 14. We lost about 5 people when they gained 14. The plan was primary care would see mild to moderate. They would then hold them and we'd see them for specialty care and they'd go back. Now they have a 4-month wait list and they're seeing mostly the people we used to see. But what's problematic for me is what's dissolved completely is the liaison, which used to be incredibly tight here. We had 4 mental health clinicians who did the triaging for every specialty referral to mental health services in town, and they did a phenomenal triage job. And then that system went into primary care. But the 14 people in that team, I get it. The things you've been talking about in this meeting are about in-house things in primary care and not about specialty services links. Because you got to watch that you don't get siloed and not connect the bridge when it's not mild to moderate and it's not a stable chronic patient. How are you linking? And so those 14 therapists have no liaison, no ongoing consultation, no connection. There's a total silo. And the quality of referrals to mental health dropped because of that lack of regular ongoing communication. And so we're swamped with inappropriate referrals. And, I said, I hate to say this because this is a primary care meeting, but I said, what surgeon would give their slate to the primary care docs? We have given 14, a third of the therapists in town are being unlinked with mental health services. And so what are we doing? I haven't heard a thing about specialty services. What are we doing about not making the error that we've made here? It's destroyed the waitlist issue.
Dr. Griffiths, if I may just respond, I see some comments in the chat too, and I just want to, from my perspective, validate what you're seeing. I think there's a need not only to think about how we deliver, of course, primary care behavioral health services, but how does that really ripple across the whole system, and how do we coordinate with secondary and specialized services within the health authority. There's one piece of what you said that I wanted to pick up on in particular, which is this mild to moderate definition, which I think has really become a bit of a problematic issue, frankly, in mental health services and the way primary care networks are rolling out in BC. Dr. Elterman shared in his slide the difference between primary care behavioral health and secondary care is really about whether it's routine care versus specialized care. And it's really, or I'm sorry, maybe this was Doctors Bowman and Beachy, my apologies if it was, but you know, that distinction between just routine care, it actually doesn't matter whether it's mild, moderate, or severe. What matters is this a primary care intervention, or is this somebody who needs a specialized approach?
Yes, and that, you know, the devil's in the details, because the distinction there has been so vague and hard to understand that all we've got is you have 14 therapists managed by primary care. Their managers, they report to people who are not trained in mental health in this small community. And then you've got 25 people who are reporting to mental health management. And you know what happens with fractures in communication and definition. So they're being told, well, you've got to send those to mental health. And we're saying, yeah, but this is a stable, chronic, severe person who doesn't need us anymore. You know, can you just hang on to them? That's where they belong. And this fight goes on. And people just wait, gets gummed up.
Yeah, and I think you're absolutely right. And I think our experience in Burnaby was that, you know, we just said, like, we take everybody. If they're being seen by their primary care GP, then they're appropriate for our program, or for the integrated behavioral health services as well. And I don't think there's any other way to do it. If you start selecting out people that are going to their primary care office and saying, you get to see your GP, but actually you have this little problem or that problem, or you're suicidal, so we're not gonna see you today, like, you undermine the entire model.
Yeah, and I think that highlights the importance of the education and training process. Is that I've worked in primary care I'm a licensed psychologist by trade. I work as a behavioral health consultant in primary care. I'm going to clinic in a few minutes, which is why I got my scrubs on, and have had the privilege of being in the same clinic for 9 years. And you see everyone and everything, and I'm trained to help with severe mental health. I mean, everything. But when folks come in and they're not trained and they're told, okay, you're going to do mild to moderate problems and you're only going to see somebody for 3 visits, people are like, okay, you triage and refer, and then you get that gumming up of a system. What we need to do is help people to really become flourishing clinicians that I know that when I step in the clinic, I can help with everything and anything, and complexity doesn't scare me, but that takes training on the front end. And so, you know, I don't know the system and the context well enough, but I do think that if certain things aren't working, it could be because the current therapists or the folks don't really quite understand what they could be doing in primary care. And I do apologize if I don't contextually know all the aspects, so I'm going to put myself on mute.
I'm totally a fan of the program. I'm totally behind it. I spent 4 years embedded 1 day a week in primary care homes, and it's fabulous. I totally get the warm handoff and being in, you know, how important that hallway chat and, you know, liaison and cross-pollination, but it's just not working. You know, it's heartbreaking. More therapists on the ground and longer wait lists doesn't make sense. Something's got to change.
Dr. Penner, Dr. Beachy in particular, I'm a clinical psychologist and my training was in Los Angeles, and I received my PsyD, and I would have had an RX had I stayed. Yay for PsyDs. And so my postdoc was, and my doctoral training also was Los Angeles mental health, and it was all what we're talking about here is integrated services. And I wanted to get out of Los Angeles. I applied here. Health Canada through in the Indian Affairs branch, as it was named back in the day, hired me, and I came up and I worked in interdisciplinary settings. It was mostly subacute. So like Alert Bay has a hospital, but they had a clinic attached that we would interface with patients in an ongoing way. And it was great because the warm handoff happened because particularly in First Nations, we need to make these really nice connections to ease people gently into the systems. And there were times where I was downtown Vancouver and I would walk patients that needed psychiatric help up to St. Paul's, and because there's lots of racism in some of the hospitals. So walking people up and making sure that they were handed off in a very firm handshake to the other clinicians saying, and this is happening and things like that. So my question is, for some of us who've been working like 30 some years doing this type of work, it would be nice to be in these settings yet again. I impose myself quite a bit with physicians and things like that. And for my clients and patients who need to advocate for themselves, and our healthcare system is rather fractured at this time. And in the Tri-Cities out in the Valley, there are no primary healthcare physicians for most of the patients in the city, in those areas, and they have to do walk-ins. And so they're just in and out the door. So one of my roles is like, okay, let's look at your labs. You can get those online. Let's check, like, how's your, blood pressure doing? Are you keeping up with your meds? Oh, I've got swollen feet. Well, did you take your blood pressure meds? So it's like really helping clients staying on top of their healthcare. So my questions to Dr. Penners and Beachy would be, for those of us who've been doing the work, maybe that eight-week training to just sort of get us right up to speed on anything else. And I know with EHR, there's not an overlap with the two different systems in place. But anyway, I'm super keen to be part of a system now. And I live on an island with 5,000 in population. We have our own health clinic, and 4 or 5 friends who are doctors in private practice, and they have integrated services, and they'd love to have psychologists. So don't forget about the islands, and don't forget about more of the remote communities. And maybe some of us can get up to speed rather quickly, and that would be my hope. Thanks for this presentation.
That's wonderful. Dan, please send us an email just so that we don't forget who you are and where you are, because actually I think, frankly, we have enough psychologists in Vancouver. There's lots of us. Where we don't have enough psychologists or counselors or mental health providers in general are in our smaller communities. So actually, I think our government really has an eye on that. I think they know that that's such a huge area of need. And so definitely glad to know you exist, and let's keep in touch.
And I think that you make a really good point that the onboarding is going to be different for every single person. If somebody has had training and they already have an eye towards the medical, and that's already been a really big part of what's going on. We had one of our clinicians who worked only in specialty care, but her mom was a nurse practitioner in primary care for 30 years. And so she was very familiar with how primary care worked. And for her, it was a 4 to 5, 6 week onboarding. And so each thing, it depends on a person's context. That's Dr. Bauman's tagline, always talking about context. But yeah, every aspect needs to be taken into context. And, some of what we say is aspirational.
To speak to your point, Dr. House, is that if our PC Psych proposal is successful in getting funded by the ministry, we'll be immediately seeking interested providers, and we'll be bringing in world leader trainers, right, such as Doctors Beachy and Bow and others, to actually establish a training a base, and that we hope to have, right, providers and practices either in person or virtually. We could have them in the province before the end of the year within trained of this model. But this again requires a big leap of faith, so to say, by our administration to realize the critical importance of integration of mental health, behavioral health services in the primary care system, but also doing things like in our proposal, it's providing overhead to every single primary care office, every single day of service, whether it's in person or virtual, that would be provided to the primary care, physicians. And so, because those are important things. So, but we're, if the funding, if we are approved for funding, we would love to have providers exactly like you that are interested in being in the primary care system, and would love to have you.
I think what is different about what we're talking about versus what everyone else is talking about, which is exactly what Dr. Penner and Zach were talking about, our healthcare system in BC is very complex. Like there's layers upon who pays whom and who's in charge of what and who gets to do this and that. And that's where the system gets gummed up, where someone says one thing, someone says another thing, nobody talks to each other. So I just want to highlight, what Erika and Zach were talking about, which is part of the PC Psych program is we kind of need to go across health authorities, which is what would allow us to get into Northern Health and to Island Health. So that I think that's a key part of it.
The one thing that I wanted to say real quick that my mind was going to is, we often get asked a lot of times, like, what makes a good BHC and who should we recruit? And I think there's some different factors to it. And honestly, though, I think a lot of the stuff, as Dr. Beachy and other people were saying, is that, there's some intentional training that needs to be done, and you're going to be able to build up these skills. The one thing, without question, of my experience that leads to people being able to be successful in this type of integration is having a unrelenting commitment to community and wanting to reach populations, and obviously like a team-based aspect, but that undeniable sense of like, I want to reach other humans and to be able to serve my community. When that's present, a lot of the other stuff that we're talking about, again, that's training, that's teaching, we can do that. But when there's that value and that mission and that purpose, that's the thing that just starts to ripple out, and it provides a context to be successful. So those people that are on this call, that's like, hey, yeah, this sounds cool, and it's a way of reaching the populations that I want to reach. It allows me to be the provider to these communities I want to be a part of. That's the stuff that gets us excited, and definitely is going to allow people to be successful.
David, I love your passion in what you just said, like that connection with core values, and that core value of like, we use the language patient and community centered, but it's more than just being centered. It's at the heart of what we do. And I think about it not only in the landscape of team-based care, but also in really in like how in longitudinal primary care, like it really is the heart of longitudinal primary care. And when we wrap that care around the patient, the longitude is really about that lifespan of the patient. And behavioral and mental health care ebbs and flows across an entire lifespan, like whether we're a child, whether we're a teenager, what I resolve as a young adult from my childhood may show up again when I'm a parent. Like it flows all the way through. And so what you just said about, wrapping or kind of being at the center, or like having the patient at the center, gave me goosebumps. Thank you.
And Lee, and here's the thing, and my mind's going to beat me up for talking too much after this, but that's okay. The one thing that gets me excited about that is like, think about just the ripple that has within communities, right? We often talk about like, we either have like a family physician or a GP or a PCP throughout our life. So could you imagine what our communities would be like if they had access to behavioral health providers throughout their lifespan, people that they have longitudinal relationships with, that are working on developing, these connections with the community and stuff. The amount of trust, Bridget and I, we often talk about, we want to make healthcare more contextual and more compassionate. When you're able to do it longitudinally, your reach, your ripple is amplified and grows exponentially. So back at you, because that gave me goosebumps what you were saying as well. It's a powerful, powerful tool.
Yeah, it makes me think of we're not only our bodies, right? And there's our minds, there's our bodies, there's our spirit. And team-based care, as much as we're, practitioners of different kinds coming together in teams and providing team-based care, it's the holism of the team, but also the holism of the individual, right?
Thank you so much, everybody on the panel, for coming to speak today. It was incredibly informative. I'm very grateful to our colleagues down in Washington State who are just so fantastic and really helping provide leadership and a really great examples of not just for in theory or an idea, like for a decade of, and showing us the outcomes, not just the outputs about how it impacts patients' health, right? The system, health savings, but also, right, the team satisfaction and how, because we know burnout is such a massive issue with our healthcare teams right now. So I'm just incredibly grateful. So thank you very much.
And not to like weirdly toot our own horn, I'm going to be like Dave, or my mind's going to beat me up for saying too much. But some of the really cool experiences of boots on the ground is when you have patients say, I've never seen a counselor before. I've never seen a therapist. I've never gone anywhere, but I was willing to give you a shot. And it's because the PCP has such, or GP has such good rapport. And they basically, in a funny way, force them to see us. But it's just that they're unrelenting. Our GPs are unrelenting and being like, I have this team member. Can you just meet with her? Can you just give her a chance? Can you just give him a chance? And there's been several of our general practitioners who say that they won't practice without a BHC, and they see that what it helps for themselves, for their longevity. And we know how important keeping our general practitioners in a good state of mind and health is. And so that gives me just such incredible, like, I'm just so honored that our general practitioners trust us and allow us to work with their patients. It's just really inspiring on a daily basis to work alongside them.
So, and one thing I want to give an example before I came back to Canada here I was born and raised here, but spent 20 years in the US training and on faculty. And before I came back to BC, we had just completed a several year study with family medicine at East Carolina University, doing integrated primary care. It was based on a grant. And one week we were gone for a conference, and they were like, physicians were like, but wait a second, where's all of our care providers? That was the running joke, is that they're like, you guys are okay, until the week we were gone at a medical conference. And now I can say, so happy that 100,000 square foot facility was built. Family medicine is side by side with psychology and the other providers, integrated behavioral medicine. And it's now standard of practice and has been for over 8 years. So, and we just, that was hard to come back to Canada to see what our primary care providers and medical teams don't have, or what our patients don't have. So I'm excited and hopeful that we can, there's people doing things like this in BC, right? One-offs, examples, but we want to help build from what people are already doing, amazing things in different groups, and start making it the standard of practice for people across BC.
And I just want to note that people are asking a lot about outcome measurement. And so, just to say that, we love outcome measurement. That is critical to us. Part of the reason we put in the primary care psychology proposal is because we really believe that mental behavioral health should be treated with the same precision, expertise, and focus on, did it work, that we look at medical health. Sometimes we talk about the fact that, you would never see an oncologist if you had cancer and say, well, I don't care if I get better. I don't care if my cancer goes away. No, that would be crazy. You would only ever see your oncologist if you knew that they were going to closely monitor outcomes, and if there was a reasonable expectation that you get better. And we know that mental and behavioral health, if it's not delivered well, not only can be ineffective, it can cause harm. And that's a big deal for us. And that's one of the reasons that we really push our government to not just look at outputs. To us, it's really not good enough to say, well, you saw someone. It's like, that's great. But what happened? Did you get better? Did you reduce your ER visits? If you have panic disorder, does that mean you didn't go to emerge thinking you had a heart attack the next day? I mean, did you save our system money? Not that that's the be all and end all, but really, if we're providing good preventative care, that should save our system money down the line. And if it doesn't, then something's going wrong. So we love outcomes.
Yeah. And so we have all of our KPIs outlined, not for just mental and behavioral health outcomes, but physical health outcomes for patients, physician satisfaction, team satisfaction, as well as other ER visits, hospitalizations, all of these other metrics. That is all in the proposal, of which we will be proposed to try and evaluate.
Erika and Leslie, thank you for mentioning the indicators. Can you name, it was one of the questions that we were going to talk about in our breakout rooms. And I'm wondering if you can share what a couple of them are, like what you think some of the key ones are. And specifically that tells us, or they can start to show how the integration piece is working.
So sure, let's just use the study from Vancouver Coastal Health that was done in 2016. So not only, they showed a range that 90% of patients came in for under 3 30-minute visits with a psychologist across the year. There was that 10% that were more high utilizers, right? But the majority were presenting for anxiety and depression and substance. And in 3 30-minute visits with a psychologist, they showed not just decreases in suicidality and anxiety and depression, but more importantly, they saw significant decreases in healthcare utilization, i.e., those patients across the next 8 months came to their primary care physician for regular appointments less because they were feeling better, right? So when we talk about healthcare utilization, we're then talking about patient attachment, how many patients a physician can actually see comfortably in a day because they know that the mental behavioral health components are covered by the psychologist and the other mental health providers as a part of that team, right? They integrate the mental behavioral health. So those are the other indicators. We'll be looking very specifically at healthcare utilization because we hope if people are feeling better, they won't need to come back right to their physicians as regularly. And also ER, right? right? We know that ERs in this province are clogged right now, that our providers cannot keep up because they're being presented not just with physical health urgent care issues, but also mental health issues that we're not able to address right now proactively system-wide within the primary care system. But we know that 90% of patients are better served in the community than needing to go through the hospital doors for care. So those are that's example one: healthcare utilization, primary care visits, all of those things are things that we'll be tracking, and based on other studies, systems, and countries that are looking at these KPIs as metrics. And maybe the last example is recently, a few weeks ago, Cigna released a study with over 2 million patients, right? That's a very big health insurance company in the US. They found that if you integrated physical medicine and pharmacy, right, as well as behavioral medicine, that saved them $1,400 per patient in those 2 million patient visits. So the fact that the largest for-profit American, right, insurance company is seeing the value of integrating mental and behavioral health services as a part of primary care, that should be an indicator to us that that's right important, that they're not doing it just because they want to. They're integrating those services because it absolutely.
Thank you. I feel like we could, just keep talking and talking. In fact, it feels like we should be, around a cozy fire with cocktails or coffee in our hand and continuing the conversation. I am mindful we're just approaching 1:30 and people have other things in their day today. I wonder if there's any just last remarks before we wrap up.
I always like leaving with a corny quote when program developments are happening, especially on this scale. Remember, when you're on the bleeding edge, you're gonna get cut, and that's gonna be a tough thing. So it's, as someone put in there, the fight's gonna be hard. It will be worth it, and making sure, like we are right now, sharing these wins, kudos, and then most importantly, having grace and compassion for ourselves, because it is tough, it is challenging as we're trying to what seems like fight up a hill that's 2 miles straight up, and you have a barrier on. But as much as possible, keep fighting, keep moving forward, because it is a beautiful thing.
Yeah, thank you guys. I'm just honored to be a part of this conversation, and I think that everybody on this call has just really fortified my spirit. So I just appreciate being involved.
Thank you. Thank you, all of you, for joining us today and sharing your perspectives and your practices. And as we wrap up, thank you to the UBC Health team for supporting this event, all the fantastic people in the background. And thank you for everyone who has joined us today and contributed to the conversation, and for bringing forward questions and ideas and your thoughts. And we look forward to seeing you at our session in May.